In this session, sort of a next step off from yesterday's session about sort of the different career tracks, this session is more about setting up a practice, specifically a thyroid-related practice. So we have 3 experts here who all have their own practices that really specifically focus only on the thyroid, and so they're each going to talk a little bit about setting up a practice in the different areas that are specific to thyroid. We have Mark Lupo, Bob Levine, and Woody Sistrunk here, and they're going to talk, and you'll have a good opportunity again to ask lots of questions. So I think we're going to start with Mark.
Thank you very much. My name is Mark Lupo. I finished my fellowship 10 years ago, and I'm in private practice in Sarasota, Florida. And I will tell you a little bit about my practice and tell you how I've done what I've done, and then Woody and Bob will tell their stories as well as we walk through some of the issues in terms of setting up a thyroid practice. And it is possible to have a wonderful, enjoyable, and beneficial career in thyroidology. So just in terms of my thyroid practice, I have a single subspecialty private practice, and it's limited to adult thyroid and parathyroid only. So I started from scratch right out of fellowship. And 10 years ago, that seemed like a daunting task, but that was my goal, was to try to do it on my own initially, recognizing I did have some fallback plans of joining a group. A couple of people had asked me to join a group, and the fellowship program had asked me to stay there as well. So I knew I had some eventual options, but I moved back from California and San Diego, where I finished my fellowship, back to Florida and started my own practice, and grew over time. So the first question people often ask about a thyroid-only practice is, what do you do with your diabetics? And that's such an important part of endocrinology, an important part of a public health standpoint of endocrinology. But to be really successful, I think, as a thyroidologist and to be able to focus on that, I think that was a tough decision in the beginning, despite one of my mentors in fellowship being a really excellent diabetologist. I never did diabetes. So from day one, I said, I'm going to do everything but diabetes, and then nutrition, the non-diabetic, everything else out. So I did pituitary, adrenal, bone, PCOS, insulin resistance, some things like that, general endocrine workups, but then attritioned all of that out, and for the last 7 years have done thyroid only. And that's been quite good. But the key was to have mentors who encouraged me to do that. So Jack Baskin was one of my mentors, as he lived in Florida, but my mentor in San Diego knew him. And Jack, as you will get to know as you understand the history of how we started doing ultrasound in our office, he was the one who said, just do it 10 years ago. And that's how endocrinologists got to begin to do thyroid ultrasound in the office. And so he was instrumental, and he said, there's no one on the west coast of Florida doing thyroid only. He was on the east coast. He said, it's wide open, go do it. And Ernie Mazzaferri, whose name is familiar to you, was also another mentor. Not that I worked directly with him, but got a chance through ATA and ACE to meet him. And those types of interactions with your current mentors and the people you meet at meetings like this will shape your future one way or another. So our office staff currently is 2 full-time thyroidologists. So I brought on someone else 3 years ago, and so there's just the 2 of us, and all we do is thyroid. I have 1 office manager, and I cannot underscore the importance, if you're going to do this on your own, or if you're going to join a group or a person who says, I don't need an office manager, you really need to have a good office manager, because you don't want that part of the headache. You want to focus on the clinical part. We have 2 front office staff, 2 medical assistants. I have a person. We have so many people calling in for new patients, which is a wonderful problem, that I had to hire a new patient coordinator. She does help the other people sometimes, but probably 75% of her time is triaging and organizing new patient charts for us. I have a file clerk and a part-time lab tech, and we started with an EMR system last year, so it's quite busy.
You don't have a nurse?
No, I have 2 medical assistants.
Okay.
Yes, no nurses. Did I skip over my medical assistants?
I saw them there, but I was just worried about a nurse.
Yes.
Okay.
I don't have a nurse. I've had a nurse in the past, and she was a great nurse, but she was toxic personality, so we let her go. She really was. It was terrible. And you have to do that when you have a small group of people and a small dynamic.
This is all going on YouTube.
If there's someone who's toxic, names aren't mentioned, then they have to go. It doesn't work, because it brings the whole crowd down. So we do have an ad out for an RN or LPN to help us out. So thank you for saying that. And we have services provided ultrasound. So we do our own ultrasound. I did try for about 6 months with a sonographer in the office who was very competent, but it did not help my workflow whatsoever. It made the patient dynamic a little bit awkward, because he would be doing the ultrasound, then I would come in and try to talk to the patient while they were still on the table, and then I would do my own ultrasound afterwards because I'm compulsive. And so it really didn't help that much and add much to it. And quite frankly, the most enjoyable time of my day is when I'm doing ultrasound for the most part, and I can talk to the patient at the same time, so you can do two things at once. We do ultrasound-guided biopsy, of course, with cytology adequacy on site. We do I-131 therapy, and we have TSH and T4 function testing on site. And we are both ECNU certified, which is critical. I'll talk about that a little bit later, and I think Woody and Bob will also talk about the ECNU certification program that ACE has spearheaded for us. And also our lab is AIUM certified, so the American Institute of Ultrasound and Medicine accredits the ultrasound lab. So people ask me this, all I do is thyroid, and other general, I'm in a relatively small town, and so when I first came to town and wanted to do thyroid only, they were very confused that I didn't do diabetes, but they didn't know my plan eventually was to do nothing but thyroid with an endocrine, and now we've got people coming out of the woodwork to come see us. So it's very possible to do just thyroid and very enjoyable, and I'll tell you about some of the benefits of a thyroid-focused practice. So it's multidisciplinary. We do everything under one roof, the ultrasound and those procedures, nuclear medicine, uptakes and treatments, and Woody will talk about that. Thyroid function lab, Woody will talk about that more. Thyroid adequacy and the assessment of the first look. So when you do an FNA, it completes that whole procedure to be able to look at it under the microscope. One, know you've got a good sample, and two, it's that first look, and you can get a preliminary read on what's going on. And you can, if it's a lymphocyte predominant looking Hashimoto's lesion, you might say I might need to do flow cytometry, or if it's a lymph node that you're aspirating that has a lot of lymphocytes that's really abundant and packed, your pathologist will teach you how to know when to do flow cytometry on those, or if you need to do other testing, or molecular marker testing and things like that. So it's not just adequacy, it's recognizing what might be happening and beginning to prepare the patient, or going back and doing a preoperative ultrasound map and recognizing that you've got papillary thyroid cancer. So it's very rewarding to do that first look. And then a team relationship's important. So we have one or two surgeons that we work with predominantly, and one pathologist that I overnight most of my specimens to. So that important team is crucial to a subspecialty niche-like practice like thyroidology. You don't want to rely on the random pathologist if you can avoid that, or general surgeons who are not thyroid-focused. Very little hospital work. So I probably go in the hospital once every month or two. The person I brought on 3 years ago has never been into a hospital in Sarasota. So very little hospital work, and that works out very well because you can focus and work very hard for 10 hours a day at the office, and then the call is fairly straightforward. You become the go-to person for thyroid. So you become the person that doctors want to send their family members to, for better or for worse, for thyroid in the community, and then people come seek you out. So even though I'm in a small town, I have people from a larger town that come to see me because it builds over time. You have improved efficiency and patient convenience. So if they're coming in for ultrasound, at that time you can do a biopsy, you can draw their blood, and you can set a lot of things up at once, whereas if they go to an endocrinologist who doesn't do ultrasound, who's not thyroid focused, then they might be sent for an ultrasound, sent back to discuss the ultrasound report, sent to the radiologist for a biopsy, sent back to discuss the results, and that's a very inefficient system, and our time is valuable, but our patients' time is also very valuable. So if you can provide a convenient, efficient service for them, they appreciate that, and the referring physicians appreciate it. Collaboration with other people who are interested and enthusiastic about thyroidology. So ATA is obviously the premier clinical and research organization for thyroidology. ACE has been extremely instrumental in the nuts and bolts of how we're able to do things in the office in terms of ultrasound, nuclear medicine, and supporting the clinical side in a very hands-on way. And then ACT is a group you may not have heard of, but it's a network of thyroid-focused clinicians who keep in touch with email. And we run tough cases by each other and describe different situations. So it's become a small, almost family-like organization of about 30 or 40 of us who share similar goals and practices. We're involved in clinical trials. We've done FNA trials, new novel assay trials for companies developing assays and things like that. So the more you're recognized as a person who might have a huge volume of thyroid patients, people will come to you to ask for your ideas and to involve you in clinical trials. You become a local, regional teaching resource, and it's the personal satisfaction of giving expert care. So we do quite a bit of diversity as well. So it's not just the evaluation and management coding, and this is a somewhat older pie chart, so Bob and Woody are trying to look at my numbers, but about half of it, we'll use the lightsaber here, so half of it is the ENN coding, and if you really didn't do much else, if you didn't do ultrasound or radioactive iodine or lab, then that would be everything you did. Now granted, if you just did this, you would have more time to do more of it, but by doing these other procedures, you do a couple of things. One, you diversify your day, so it makes it a lot more interesting. And two is you spread out your reimbursements over several different codes, which is important because as coding reimbursements change over time, if you, these things will change. It's a little bit of an allocation of diversity that makes it, if something changes, you can make some adoptions. So I would say my lab is a little bit less than it used to be. My radioactive iodine might be a little less as well. So probably more ultrasound on that pie chart if you're thinking about it. So how do you code that? And that's important. So if you're out on your own, or if you've joined a group, or if people are looking at your RVUs, you're going to want to be able to understand not only the diagnostic ICD-9, soon to be 10 codes, but what the ENM and the CPT codes are. So go to an endocrine coding seminar. Rely on your coding specialist and your billing specialist. It's either in the office or in your facility. But if you don't know what all those things mean, you might be losing out. So make sure you do that and understand the procedure codes you have, and make sure they have an authorization before they put the foot in the door. So the way we do this is to have all of our possible codes authorized before the patients even come for their first visit. So they're authorized for ultrasound, for biopsy, the whole thing. So we have all that documented. So procedural coding, I'm not going to spend much time on this, but as you're going into practice, either starting on your own or whatever, these are the basic diagnostic ultrasound and biopsy codes, as well as cytology, assessment, and radioactive iodine codes. And these are in addition to the codes of ENM. Now, cytology is important, and this is part of what will be a natural addition or extension of the FNA procedure. So the 88172 code is meant to be an on-site adequacy assessment by the person performing the FNA. It's not for the pathology lab to look at and say it wasn't adequate, because the idea of the code is that you can make a change at that time. If it's not adequate, you can go back and do more. So this is a physician-performed microscopy for adequacy, and currently CMS, the Center for Medicare Services, says that that's a CLIA-waived code, even though there's extreme confusion from state to state on this. So if you start using this code as you go out into practice, pay attention to reimbursement and pay attention to any state changes, but it's supposed to be CMS waived. It improves your FNA skills. I mean, for those of us who have done 3,000 or 4,000 FNAs, it may not improve it that much, but when I was first doing adequacy, that first 500 to 1,000 biopsies, I think my non-sat rate dropped significantly when I started looking at it myself and maybe changing techniques for vascular lesions or cystic lesions or calcified lesions that are notoriously difficult to sample sometimes, and it allows that first look to determine if any more testing is needed. So cytology should be incorporated. So at this point, hopefully you're saying that you want a thyroid practice too, and it's very doable, very possible, but how do you do it? 10 years ago, it was kind of daunting to start one on my own, and even now in the current environment, it's hard to recommend to someone just to go out and start it from scratch, but that still is a possibility. You can join an existing thyroid practice, but there's only a handful of them out there. You can negotiate with your group or multi-specialty clinic, and the key here, as people have said, if you want to define what your practice is going to be and you're entering into a contract, make sure it's all in the contract before you sign it. So if you want to be a thyroidologist, ultrasound is the cornerstone of that. You cannot do a thyroid-focused practice without ultrasound. So if you're going into a multi-specialty job and they say, we'll see about giving you ultrasound periodically, that's not acceptable. You need to put that in your contract before you sign it to make it very clear to everyone that that's a priority to you. Because once you're in there, you may not get it. Bob's in it.
Well, I was just going to say, and in that contract, you want the no diabetes, because in many multi-specialty groups, they're saying, well, we're bringing in an endocrinologist. We'll have you do a little bit of the diabetes, and as time goes on, they will put more and more and more until you don't have time.
It'll be 75% of your practice before you know it. So if you have a goal in mind when you're sitting down for that first contract, before you sign off on it, as eager as you are for all the signing bonuses and things, make sure it's very clear that that's what you want. They need you. There's a shortage of endocrinologists, so you have the bargaining power, so make sure you exercise it. So the key is access to ultrasound, and ECNU certification, which is the endocrine certification in neck ultrasound, underscores your commitment to doing thyroidology. Not only does that do that to your patients when they look up what ECNU is, to referring physicians, but eventually to third-party payers who are wondering, why are you doing diagnostic ultrasound? That's a radiologist's job. And this certification says, no, I'm vetted by the AIUM, which is a radiology group, to do this type of study, and my lab is accredited by that same group. So that's important if you can, while you're doing fellowship, to get the ECNU certification, which is quite possible during fellowship, to pursue that. So we've talked about this a little bit. So those of us who are wearing ECNU pins, if you don't recognize this logo and this branding of ECNU, this has been a huge venture by the American College of Endocrinology that not only involves a pathway for endocrinologists to do this, but also cytopathologists and surgeons and ENTs as well. So this is a very important and huge step forward in recognition of what we do. I'll skip over this because it's on the website. So practice models, there's different ways to do this. So solo private practice is what we have. Group practice is joining maybe a group of endocrinologists and then trying to carve out thyroidology from within that. And that's what Woody did initially, then broke on his own, so he'll tell you about that. Multi-specialty practice would be joining a group with lots of specialties and then trying to carve it out, which that gets even more and more difficult in hospital-based practice. And I know you've had talks about academic institutions. So I'm going to just go through a little list that I've wrote part of this. I think Woody wrote part of this at one point as well, of kind of the pros and cons of solo versus group. In solo, you have all the responsibility. So those of us who are very compulsive, we want all the responsibility because we don't trust other people to do that for us. So that's great. But in a group, you have shared responsibility, which is also nice. That means shared call and things like that. But in thyroidology, remember, there's not much call. So it's not as critical as you think about some of the other specialties. You make all the office protocols, which is good. So you can do things your way. But if you have other people, then they might have input, which might be very wonderful input, or it might be input that ends up not being your view of things. You can change things whenever you want. So I don't have to have a committee meeting to figure out if I want to buy an EMR system or change the way my back office works or change the way we do any protocol in the office. In a hospital, so the bigger your system, the more committees you have to go through to try to figure out how to get things done. You pay all of the overhead. Well, that's kind of scary. That means everyone else and everything else gets paid before you get paid. So there's a certain kind of number in your head thinking, okay, I've got to pay all my staff, I've got to pay my rent, I have to pay all these things, and then I get paid. So that's a little bit daunting, but it's also very rewarding. But for people who don't like risk, then they might want that shared overhead. You cover all the patients, which is okay in thyroidology. And then it must be compared in a group. The other thing with that, you're on your own here. In a group, the divorce rate for medical practices is about the same as divorce rate for couples in this country. And anyone who's been around medicine long enough will tell you maybe it's even worse. So you have to consider your partner, your associates, as your spouse. And that's going to be because you're going to spend as much time with them and making key big financial decisions with them as you do your real spouse. And a divorce in that way can be as disruptive to your life as a divorce otherwise. So take these things seriously when you join someone else. So basic considerations. So if you're doing this on your own, you need money. And you don't have money coming out of fellowship, you go to the bank. And the bank's not going to just give you money because you have an MD. They used to do that, but they don't do that so much anymore. So you need a business plan. So you have to go then figure out how to write a business plan. You can have an accountant write one with you, and maybe a lawyer write one with you. But I just did a Google search, or whatever search was available 10 years ago, and wrote my own business plan based on a few models that I saw. And that worked pretty well. You need a corporate structure. And you need an attorney on your side for several things, corporate structure and maybe some negotiations with insurance companies. And Bob's going to talk a little bit more about that as well. You need to have some space. So you want to probably rent at first. You don't want to go buy a building because that's another expense from the beginning. But initially rent and figure out where you want to be. You don't want to be in the cheap rent strip mall district that people don't recognize as a medical area. You want to have an office that's recognized in that community as clearly a medical-oriented geographic area. You want to hire a good office manager because that person then can hire the rest of your staff with you, and that's key to take that off your plate. You have to deal with the Medicare and insurances, and that takes 3 to 6 months to get on Medicare. You have to maybe get a new state license. You've got a lot of legwork to do there. Billing and payroll, you have to bill. and you either do that in office or outsource it. You can outsource that to a billing specialty company, and they'll take a small percentage of your payments for that. But that's probably an easy way to do that. Yes.
Can I interrupt? When I started, I did it in office. My office manager, when we were a very beginning practice, just did all the billing in addition to everything else, and she had experience in it. And as I expanded and grew and saw more patients, one day I was sitting at a meeting like this, and one of the people I had been fellows with years before said, what's your gross right now? And I told him, and he said, actually what had happened is after we expanded a bit, we then hit a point where I said it's just too big for the office manager to do it, so we hired a billing company. And they were getting 7%. Right. And then I was sitting talking to somebody, he said, what's your gross? And we went through the numbers, and he said, you realize that what you're paying that billing company is 2 full-time salaries for a office personnel like that. And you could really bring it back in-house at this point and hire one person to do it the full time. So I actually stole the person from the billing company who was my account executive. She was thrilled to leave that company and come work for me because she had to run 3 accounts somewhere else, and she had 2 people who punched numbers for her. But she could do the whole thing herself, work a 40-hour week, and have plenty of free time to schmooze around the office. And I saved 50% and made like an additional $35,000 the year I brought her in because I stopped paying it out to a company. So you want to think about which is the more economical, and probably start in-house, ship it out at some point, but then bring it back in when it's that. And that's
we started shipping it out, then we brought it back in, and we took the person from the billing company who had our account as well, and she's. So that's exactly what we did, because we did the same math, and you say, wait a minute, I'm not going to pay 6 or 7% out because that is 2 full-time salaries. So, that's a very good points there. And then with the equipment, so obviously if we're going to buy ultrasound machines, we have to talk to your accountant about the pros and cons of leasing versus buying equipment. And you want to have service contracts on them because if something goes wrong with them, you want to be able to have a new ultrasound transducer the next morning to keep working. Find a very good accountant. You have city and county licenses and lots of forms and policies. So I think if you're starting out and you don't have an office manager with a lot of experience, hire a consultant to help you and have set these things up. Make sure you've got all the hospital credentialing, insurance company credentialing, and all of these things. And there's our consultants who will walk you through all of this. Then you want to market. I'm going to go through this quickly. Market yourself. So you want to give local talks to patients and also to doctors. You want to go to the doctor's lounge, which now I avoid as much as possible. You send letters to the doctors explaining your services and use good letterhead. Let your letterhead market for you. So on your letterhead, it's just not going to be Dr. Smith. It's Dr. Smith, and my specialty is I provide these services. So radioactive iodine, physician-performed ultrasound, on-site adequacy assessment, etc. And then eventually, probably for us, viral marketing. So viral marketing means word of mouth has been the most important. We have a website, but otherwise I don't do any other marketing, and over half of our patients are word-of-mouth patients from friends or other patients already. So if you build it, they will come. There's a shortage of us, so take advantage of that. And then lastly, this may not be completely true, but choose a job you love and you will never have to work a day in your life. And I very much have a hobby and a job at the same time, so I'm very fortunate in that way. But there are days where I definitely am reminded it is a job. So as I think it's been a wonderful medical career for me, and look forward to, as always, hearing about Bob and Woody's practices. So, thank you. You're an endocrinologist. Yeah, I would say I understand that point. You lose some of those skills, but we're all very, very bright, compulsive people. That's why we're in this room. So if you needed to pick up new skills again, you can do it very quickly. And because we don't have a lot of procedural skills and we have a lot more cerebral skills, we can relearn I had to recertify for general endocrine last year. Okay? And that was, I had to study a little bit, but it was an easy test to take. So you can reacquire skills.
And if I can expand on that as well, I consider my practice not just only thyroid, but basically structural thyroid. Because of my affiliation with ACE and the ultrasound, I've managed to have the other people in the office see the hypers and the hypos, and basically I do thyroid cancer and nodules. But there is about every couple of weeks a phone call from a physician who says, they just found an adenoma in my adrenal gland, and I really don't want to see anybody but you. Are you willing to see it? Or, a pituitary tumor may come along. I certainly have kept absolutely no diabetes, but I will every so often, and I've got patients that are left over from the beginning of my practice when I did a more general endocrine practice, and I'll tell you the whole story in a little bit, but I've got patients left over with pituitary tumors that I've seen now for 20 years. I'm not going to let them go and say, you got to see my partner. So I still see them once every year or two. So you will dabble in the other things. And remember, your thyroid patients, if they have if they have an MEN syndrome, you now do have to remember things like pheochromocytoma screening. You do have to remember things like pituitary tumor. So because of those patients, you're going to stay in the current for the rest of the endocrine world.
I would add to that when I went off into practice, I joined a group of endocrinologists that they did a lot of internal medicine, they did a lot of hypertension, they did a lot of diabetes. And I have not found a nurse practitioner that I can be as good as to tell them, you got to take your medicine, you got to eat less, and you got to check your blood sugar, And the thing is that, this is where you will get put as an endocrinologist in a group practice, is telling people that they're not managing their diabetes and that they're a slob and that they must do a better job of it. And, for me, I can ablate a lymph node with alcohol. Anybody down the street can tell them they need to check their blood sugar more. But this becomes a very, very specialized thing that you are capable of. And so don't ever forget that, Otherwise, to Blue Cross Blue Shield, you're just another warm body. They don't care that you're an endocrinologist. They don't care where you trained. You're a warm body seeing diabetes. This is something different, both for you, for the patient, and, satisfaction. So it's rewarding. Let me talk about a few practice enhancements. I was in a group of endocrinologists and went off on my own in 2007, so I'm 5 years into a thyroidology practice. But first I want to show you this. This is my opinion, and I would sure have some dissenters on the podium here, but I think having lab is critical, and both as a convenience factor and for profit is a great idea. Ultrasound is critical. I would be quick to say that cytology in the office is great. You just have to say, yes, I see enough cells, or no. But I'm going to talk a little bit about nuclear medicine that I consider number 4 on that list, but certainly is an enhancement. How many of you all had any nuclear medicine training in your fellowship program? A few did. Boston, are you from, or where are you from? Where is that? NYU, excellent. And so I'm going to talk about 2 things: outpatient nuclear medicine and the private practice of endocrinology, and talk about starting a lab. In the introduction to this, I want to just go over a few things. Now, one of the things is that when I first started in my fellowship program, I heard that somebody went off and got a nuclear medicine license to give radioactive iodine therapy in fellowship. And one of the things this intrigued me, that this was even an option. And so I always wanted to make sure that people know it is an option. Now, when I got back into practice, one of the first things I had one of my former high school classmates that said that she had Graves' disease and had radioactive iodine therapy. I said, well, what did they tell you when you took the tablet? She said, in that room, you'll find a metal box. In that box, you'll find a lead container. In that lead container is a pill. Take it and leave as fast as you can. We can do a lot better job than that. So, as endocrinologists, we are able to do thyroid uptakes in the office, radioactive iodine therapy for both hyperthyroidism and thyroid cancer. And this gives you the ability to still interact with patients, to make sure that quality work is done, make sure that outcomes are good, and make sure that patients' questions are answered. Let's talk a little bit about what does it take to do this in the office. Well, let's talk a little bit about history. The iodine-131 therapy started out with endocrinologists, 1946. Some of the earliest cases were endocrinologists, Saul Hertz and associates. Between 70 and 93, nuclear medicine had pretty much taken it over. Between 1993 and present, you'll hear the name Jack Baskin again. Jack Baskin and the American Association of Clinical Endocrinologists undertook an initiative to teach people to make sure that we had the ability to have the radiation physics to get nuclear medicine licensure. In the nuclear medicine era, you all live through this. You see this on a day-to-day basis. The thyroid uptake is low, compatible with hypothyroidism. I can't tell you how many subacute thyroiditis I've seen with a free T4 of 3.5, and the nurse practitioner sees, oh, the radiologist says they're hypothyroid. Maybe I better go ahead and start them on Synthroid now, even though their free T4 is 3.5. Or one of my personal favorites, the thyroid uptake is low, rule out perineoplastic process. They just make up stuff. It's terrible. Let's talk a little bit about licensure. So it depends on where you live in the United States. We have agreement states and non-agreement states, okay? If you're in an agreement state, this means that your state has agreed with the NRC that we will be just as stringent as you are to make sure that all of the laws are followed. If it's a non-agreement state, it means that the NRC is the one who you apply to for a license. The radioactive materials license that you're after here is issued to your clinic, and that gives you the ability to order, receive, possess, and use radioactive materials. And what you're trying to be as an authorized user on a radioactive materials license. Now, any of you all who do have training in fellowship, do you have the opportunity to get on a license, or have you gotten your caseload to get licensed? Do you know? Just had some experience. Okay, let's talk a little bit about that. Well, what you'll be able to do is iodine 131 and iodine 123 uptakes if you do this in the office. Radioactive iodine therapy for hyperthyroidism and thyroid cancer. One of the things I want to make sure you're aware of is you will not be having a gamma camera, so you will not be doing thyroid scans. Now, I would say this, is that do I send people for thyroid scans that are hyperthyroid? Sure. The first thing I do on a new patient consult, I see somebody hyperthyroid, I'll take a liquid ultrasound at the goiter. If I see nodules, I'll send them for an uptake and scan. If I see no nodules and everything is typical of Graves' disease, I do a thyroid uptake in the office. So that's the scenario that I go. So to become an authorized user, you have to have 80 hours of classroom instruction. And this is one of the things that ACE has been really helpful in establishing an 80-hour course to make sure you have all the math and physics and all of the other background associated with having a nuclear medicine license. You also need board certification by a medical specialty board, and that could be endocrine or internal medicine. Supervised treatment of 3 patients less than 33 millicuries and 3 patients more than 33 millicuries. And so we do have another ACE nuclear medicine course that's going to be about 1 year from now. That's usually in Kansas City, Missouri. But certainly I'd be more than happy to answer any questions about that afterwards, because it's something that if you're interested in, can certainly be carried out. One of the things is that, if you're interested in getting a license in your particular state, gosh, call the state, tell them your plan, or you may be able to find somebody else who is in your state who has a nuclear medicine license. One of the things that I did is I was trying to write a license, and I contacted the nuclear pharmacy, and I said, gosh, I'm trying to write a license, and they said, let me help you. And so, by all means, they want your business. So there are a lot of people out there that will help you, but I'm certainly here and always happy to field any calls or questions about this. To have a hot lab in the office, let me just give you an overview quick of my procedure room. This is my uptake computer here, that it goes through a wire up to my uptake probe here. But you see I still use this same stretcher for my ultrasound and biopsies. And so it's helpful to have it there. Now, everyone thinks it has to be really complicated. Gosh, the cardiology clinic across the street from me has this very fancy nuclear patient's restroom. But, most of the time, if you're given radioactive iodine for thyroid cancer or hyperthyroidism, you walk them out of the building, make sure they're on their way, make sure they go to the bathroom before they leave. So you don't need anything this impressive or fancy. And so in the procedure room, gosh, you can use the same procedure room for radioactive iodine. I have that twice. I don't know why I have that twice. In the back of the room, I have my microscope. We've talked a little bit about microscopy. But the main things you need an uptake system, a dose calibrator, a Geiger counter, and it basically costs about $24,000 to get all of these things up and going in the office. Now, if you think right now a good ultrasound machine, a really good ultrasound machine is about $50,000. This may be something that as you go interviewing and looking for a job, you may want to say, gosh, I need $75,000 set aside for equipment. And so... Question?
I'm just saying a really good one. I'd say
a really good one. A really good one is $50,000. Okay. What was a real good one? 75?
I'd say a real good one is 70, and a A good one is 40.
40. Okay. Really receive very minimal exposure, but of course you're wearing film badges, so you know if you're exposed. I want to show you this because this gives you a little bit of perspective. As I've been in practice now for about 11 years, and this was at the end of last year, I've done about 865 iodine-131 therapies in the office, but that compared to 10 years and 11 years in practice versus the ultrasound volume on a yearly basis, ultrasound is critical first. And so by all means, if you're thinking about any of these things, I think lab is critical. I think ultrasound is critical. But while in fellowship, one of the things that you can do is go ahead and get your preceptorship for your 3 patients less than 33 millicuries that are hyperthyroid, and the preceptorship for the greater than 33 millicuries. Those cases will carry over into your private practice. So if you're at least thinking about it, it can be done. Make sure while you're interviewing for a job that you have money set aside for a good ultrasound machine. Be very specific about the money-making potential of these things, and by all means talk them into a good ultrasound machine on the front end. One of the pathways to licensure for the nuclear medicine is, again, the 2 cases, 3 hyperthyroid, 3 thyroid cancer. You can take the 80-hour course from AACE. We have what's coming next is the Certification Board of Nuclear Endocrinology, that mainly is going to be a certification board that is accepted by the Nuclear Regulatory Commission for our preceptorship, for our teaching. So in essence, every state will have to accept that. And after you get licensed here, we talk about lab accreditation. A lot of reimbursement is now going to be associated with your practice, not you, but your practice being accredited. And I know from Medicare, this is something that is required for nuclear medicine codes. And so my lab is ICANN certified. One of the things that we have a problem with is a lot of people who take the nuclear medicine course have a hard time getting their preceptorships. And that's one of the reasons why we do have and we were working on the Certification Board of Nuclear Endocrinology to set up preceptorships around the country so you can go and get your casework done. Certainly, it's critical to know that we have thyroid doctors treating thyroid disease, but a thyroid practice is certainly a reality. And yes, my goiter is gone now, and I'm well and happy. I'm going to talk a little bit about lab now, if that's okay. Are we on time?
Yeah.
We're on schedule. Chime in on any of this. Bob doesn't do nukes.
Don't do that.
Yeah, Mark does nukes.
And I did all of my cases during fellowship, so it was easy once I got out to take the course and submit my application.
See, when I was in fellowship, I did my 3 and 3, and then I got the course, and then I went to the radiation safety officer I was at Mayo at the time, and I said, I want to be on the license. He says, are you crazy? I said, look, I'm in fellowship, and I want to be able to transfer that license from here to where I'm moving. And they said, no problem. So they had a vote of the Radiation Safety Committee, and they put me on the Mayo license, and then it became a transfer of license.
Even better.
Even easier. Again, we go back to the thyroidology practice options. Let's talk a little bit about point-of-care laboratory. How many of you all have already signed a contract? Raise your hand. Good, good. First-year fellows, are you? First year? Second year? Third year? Most of you all are on 2-year programs, right? It's getting to be time to find a job. Anybody needs a thyroid job, come talk to me.
Or me.
Any of us. Let's talk a little bit about lab outline, because one of the things is it's kind of a daunting task to think about. Gosh, setting up a lab, I really need some heavy equipment. Never enough heavy equipment. Never quite enough equipment there. And so, with that said, let me ask you a couple of questions. Who is this man? Anybody know who this is? He invented the radiation film badge. He invented polarized lenses. And he changed our lives forever. Does anybody know who that man is?
Edwin Land.
Edwin Land. Good job.
Did I guess right?
You guessed right. Edwin Land was the inventor of the Polaroid camera. Anyone know what a Polaroid camera is, or are you all too young? It's these ones that's called a one-step. You push the button and it goes zzz, and the picture comes right out. When the Polaroid camera came along, one of the things that it really changed a lot. He also invented polarized lenses, film badges. But how did he change the practice of medicine? Let me tell you this. Everybody's expectation of everything, whether good, bad, or ugly, the expectation of things being available immediately were changed by the popular culture and the Polaroid camera. And so, certainly, patients have not forgotten this as we're all sitting with our iPhone, texting people and knowing where we are immediately. Laboratory medicine, of course, is the heart of endocrinology, but if you don't have lab, you're doomed to watch and guess. And a lot of our some of the older slides that were shown today were when T3 was new or TSH wasn't available, and the basal metabolic rate and body temperature. And in 1942, we didn't have a TSH. We were forced to guess. But I'm so tired. It must be my thyroid. It's got to be my thyroid. The decisive no is absolutely priceless in clinical medicine. Let's talk a little bit about CLIA lab certification. With laboratory certification, you can have a laboratory-based office, which is defined as a clinical laboratory in your office that gives you the ability to test specimens and is usually located on-site. You become the lab director responsible for all operation of the lab and competency of the lab personnel. Well, how do you become a lab director? Well, you can go ahead and go back and do that year in anatomic and clinical pathology, and you all might be excited about cytology and want to do that, but I don't think I would. 1 year of laboratory training and residency. How many had a 2-year fellowship with 1 year of lab training? Okay, do you guys have lab training and fellowship? Raise your hand if you had lab training. No lab training. 2-year clinical. Everybody 2-year clinical. Interesting. Still time to do that. Or the other thing you can do is take the 20-hour course. So all of you all could take the 20-hour course online about lab directorship and lab university. And so this is available if you're willing to do it. And so how do you set up a lab? How do you make up a lab? Well, laboratory director, the one in charge of everything, that would be you. A technical consultant about deciding the scientific oversight of the lab or everything going well. That can be you as well. Clinical consultant. Who decides what tests are appropriate for what patient? That would be you again. But testing personnel, even though Joel Unkrantz, have you seen his iPhone that you can test the TSH with? It's coming in the abstracts tomorrow. I said, Joel, you're going to get blood on somebody doing that. That's a bad idea. But thankfully, you'll have other testing personnel. And so, basically, having a TSH and free T4 is an essential part of the enterprise. In my lab right now, in my office right now, from the vein to a paper result in their hand and in the electronic record, 20 minutes. And so, you can have a face-to-face review of the labs. How many have that where you are right now? Anybody? Face-to-face lab review. Who calls the patients back? The fellows? Wouldn't it be great to say, you're good, here's your thyroid hormone prescription? Or the TSH is 100. I swear I'm taking my medicine. I said, stand back, lightning's going to strike you. You have a lot of menu of things that you can do right in the office. For me, right now, I have the single instrument, and I can do a TSH and free T4. I could do chemistries on that same machine, but I choose not to, just because my chemistry volume is so low. You can do CLIA wave tests, and that would be tests like pregnancy tests. I use a urine pregnancy test before I do a thyroid uptake. But note that a CLIA license is not required for FNA adequacy right now. Is this correct? That's correct. Yeah, making sure of that. So, laboratory improves clinical outcomes, faster diagnosis and treatment, improved patient compliance, and I would say as we all get busy in the thyroidology practice, and we see the 85-year-old lady whose TSH is 2.5, and she's on Synthroid 100 that she's been on since 1955, you can say, gosh, your family doctor or nurse practitioner can recheck this in 6 months, and I would say, yearly thyroid function test and a yearly neck exam as part of your yearly annual exam, and I'd be more than happy to see this pleasant lady back in reassessment on an as-needed basis. But you've got to make yourself available to see new patients. And so one of the things is that unless you want to see them forever and ever, amen, you got to have the ability to send people on their way and say, you're in good shape, come back and see me if you get into trouble. One of the things that's nice as well is if you do have an in-office laboratory clinical research, I know Mark and I both were approached about a laboratory study that was being done looking for thyroid volume, and we have thyroid volume, but Mark is doing that now. Yes. He's in the study. I opted not to for now. One of the hardest things about having a lab, though, is it does cost. It does cost. There are regulations involved. There are personnel involved. But one of the things that I'm going to make sure we have, I thought I had a slide about cost. Let me go back to that. But one of the things is that, when you go looking at things, everything costs. For me to have a lab in the office, that's about $250,000 a year. Okay? But if you think about that, is that with what I do in the office, the laboratory I do bill for. And when you bill for the laboratory, you can charge for the laboratory. And so the question becomes is, if you're able to do all of this face-to-face, you think about the amount of time you save. You think about the people hours you save by being able to do this face-to-face in the office, meaning lab drawn, patient seen, lab available, imported, send the prescription, disposition made, and you can do that all in about 30 minutes and be done with it. And patients like the convenience. They don't want to be worried about you calling. If you don't have face-to-face lab, you need another nurse, and that's $45,000, $50,000 to call all those patients back the next day, call all the pharmacies the next day, track people down the next day. So set the standard with this in the office. Fewer phone calls, faster diagnosis and treatment, less anxiety, less concern. Gosh, I always worry about, did I write the right dose of Synthroid on that prescription? We go over it with them. We talk about it face-to-face. And of course, having the ability, one of the most important things is the obese and tired say, let me get you a good internist. So lab is good for the patient, it's good for the practice, it's good for revenue, and it's good for the physician as you knowing exactly where we are on things. Those are the figures there, and I went through some of that already, but let me just go. But again, about $250,000 a year for having an in-office lab. One of the things that I really like a lot with the F&A, like Mark spoke of, is the F&A adequacy as another vital lab function. Now, one of the things right now is I have the lab tech in the back of the room doing the diff quicks on every F&A biopsy. And one of the things I started thinking about is that, gosh, I can almost pay the lab tech salary on what I get from the diff quicks only. And so it's great to have her back there staining while I'm doing my biopsies. And so she has the slides ready. She goes, we're good. We stop. She'll be able to tell me, and I go look at the slides myself, but she can tell you you've gotten enough cells, you can stop sticking. And so one other thing, I'll make a couple of points, and I know Bob is going to have time to talk as well, is if you're going to have a thyroid clinic, by all means have thyroid in your name. If you have diabetes in your clinic name, you're a diabetes clinic, period. Set yourself apart from others. Be visionary, not reactionary. Meaning, don't decide you're going to do this after somebody else in your town does it. You be the one. You be the one that has the ace in the hole. You may not be able to do all of these things at one time, but have a vision, have a plan for these things. I'll use a different quote to end on, since that quote, I've seen that quote before.
Did you? Oh, have you had that quote? I didn't.
So I have a different quote. Do the work you love, and you will find joy in it. And I would point out to you that although he could have gone into playing the accordion, that Lawrence Welk's grandson, what did he do? He's an endocrinologist, like the rest of us. Excellent. Questions for me? Yes. Talk to me afterwards. I know I'll give you some contact names of some people to talk to in those hospital systems, because they're really looking for some help. Yeah, they really are.
But you make a very good point.
Yeah.
And that's, as we're looking at the evolution of healthcare under Obamacare and ACOs and all this that's going on, we're looking at a very changing face environment. When, unlike these guys, I've been at this for a longer time. I finished my fellowship 25 years ago, and I set up my independent practice 21 years ago. And at that time, there already was one major player. The Dartmouth Hitchcock Clinic was in my town, but they took about 20-30%, and the other 70-80% were independents. At this point, one of the hospitals in town has hired their own group. When I set up in that town, there was virtually nobody else doing endocrine for about, a population of 80,000. Now there's 5 endocrinologists there, but I established myself as the thyroid person.
Point person. Make yourself the point person.
If a lot of patients certainly go to the other endocrinologists for other thyroid issues, but the second they get a suspicious thyroid biopsy, or an insufficient thyroid biopsy, they know that there's somebody in town who has the thyroid clinic of New Hampshire. And therefore, they say to their plan, your endocrinologist didn't get a good biopsy. They want to do it again. I want to go to the guy who wrote the textbook on endocrinology. So, it's evolved that way, but you do...
He did write the textbook, two versions.
You may not want to set up in an area that has that big of a market capture as an independent. You may need to go to them and say, I can do a better job for endocrine for you, and I want to set up the thyroid practice for you, as opposed to trying to set up a completely independent in that type of environment. We don't know what's going to happen. I've been completely independent. Mark said he hasn't stepped foot in a hospital in 3 months. I haven't stepped foot in a hospital in 3 years. I love it. I used to spend a lot of time going to the hospital to do consults. But as a thyroid practice, there's no reason for me to ever see a patient in the hospital.
There's nothing like hyponatremia on a Sunday afternoon.
The last time I went to the hospital, it was wonderful. It was for about 7 years ago for myxedema coma. And yeah, that was fine. I didn't mind that on a Saturday afternoon, to really see somebody who needed to be intubated for hypoventilation. It made my day. But I'm now looking at approaching the hospital that has one endocrinologist, and they do mostly diabetes. I'm going to talk to them about 1 or 2 days a week where I will see patients in their cancer center as thyroid cancer and nodules only. I'm going to approach the Dartmouth-Hitchcock network about possibly doing the same thing for them. And so I'm looking proactively at what's about to happen, where they're going to need for their accountable care organization somebody who can provide a cost-effective...
complicated thyroid care.
And we're in an era right now where they're going to have to show that they're doing it. We're in an era where thyroid nodules are epidemic. And that institution, they're going to be doing CTs and carotid ultrasounds, and they're going to be finding thousands of thyroid nodules. And if they have somebody who's not a good thyroid person, but who dabbles in thyroid on the side of their diabetes, and is going to send their nodules to their radiology department where they'll get a lousy biopsy and then need it to go somewhere else, if you can approach them and say, I can do this better, and this is Mark's business plan, I can do this better for you, and I can make it so that under the ACO guidelines, you're going to show that you're doing this particular disease state very efficiently, then they may want you.
The one other thing I would add, and your concerns about what do you do about the patient who comes to you and says, I have a 5-centimeter thyroid nodule, and oh yeah, my diabetes is out of control. And a lot of people do want one-stop shopping, but one of the things that I have done is that there is a good group of internists that their specific interest is diabetes. And so I make a point to send every diabetic patient, I'll refer them. I don't mind about referring them, but in turn, now we have internists managing diabetes, and internists are obsessive compulsive. And everybody wants to be on Victoza, and so everybody's getting a thyroid exam. Everybody's getting a thyroid exam, and what do they find? Thyroid nodules. Is it medullary cancer? We'll figure that out for you. We're happy to sort that out for you.
And the other way you can approach that diabetes, I send them to the head of the Joslin Diabetes Clinic in town, and even though he likes to do thyroid biopsies, he's terrible at it, so he's now sending me more and more of his diabetes, of his thyroid. And when he finds a thyroid cancer, he does say to the patient at this point, and he's happy to do it because I'm sending him diabetic patients and getting the referrals. If he finds a thyroid cancer, he says to the patient, I don't have expertise in managing thyroid cancer. I'm going to send you to somebody who is a thyroid specialist.
There's plenty to share. I'll tell you this, so I'm in Jackson, Mississippi, and we have some good general surgeons that do a good job of thyroidectomy. We have some general surgeons that do a pretty reasonable job in the central neck. But if you have a 35-year-old young lady who has lateral neck disease. You have a very frank discussion. You confirm it with an FNA, lateral neck disease, and you say, gosh, I think you would be well served to go to a tertiary referral center. Let me help you make that referral. Let me get that squared away for you. Because, on the front end, not for the second surgery, on the front end. And this is something that over the years, you sometimes find yourself having to call that general surgeon who sent them to you and say, I'm very concerned about this. I want to send her out to MD Anderson, because I've had a few soccer moms who had Graves' disease and thyroidectomy and could never yell again, barely talk again, And so you gotta be able to call the surgeon and say, I'm really concerned about this one. I want to send them off to another location, to a tertiary referral center. And most are fine with that, and a few will hang up on you and won't send you any more business. But, you don't want any part of that,
And let me put a few tails on that. I'm in one city. I cover a city north of me as well. And in my town, there's one surgeon that I use. So there are two hospitals. He only goes to one of the hospitals, but he's very good. The other hospital, fortunately, just got some good ENTs who are coming up from the Mass General and operating there. The town above, there as a group with two ENT surgeons. I never used ENT surgeons. These guys came to me at some point and said, we just finished a very high volume fellowship. We did lots and lots and lots of thyroid surgery. We each did 200 cases during our fellowship, and we want to be your thyroid surgeon for this area. And I asked them a few questions. I said, if a patient has a level 3 lateral lymph node, what's your operation going to be? And I wanted to see, I'll take out the lymph node, or I'm going to do a compartmental of low 2, all of 3, and 4. And I got the right answer. So I said, I'll try them a few times. They were great. And they now get 30 or so cases from me alone per year. The guy in my town gets about 30 from me. But as Woody said, when at the beginning of this summer, in came a 20-year-old student at the Boston Conservatory, voice major, who somebody had felt a little enlargement of her thyroid, and when I put the ultrasound machine on, she had at least 15 nodes that I could check. I said, there is only one surgeon who's going to be good for you, and that's Greg Randolph, and I'm 45 minutes from Boston. So I said, you will go see Greg Randolph. And to put a nice ending to that, Greg saw her quickly. He operated on her. She started the semester on time and just landed the lead in the first play that they're doing. So.
No, I would say this, is that I would say if you have lab, if you're doing general endocrine, even more reason to get this lab have your own lab. And the other thing is your lab tech can be the one helping you dip the slides. Yeah, that's what I have. Yeah, go ahead.
Talk about a few other things. In terms of that, as I said, I've had my practice now for 21 years in Nashua, New Hampshire. When I moved there, I said, I'm going to do general endocrinology and no internal medicine, which was a shock to the doctors in the community because the cardiologists had some general med, the pulmonary docs had some general med, and that was the standard of care at the time. And I came in and just rocked the boat by saying, I'm not going to do general med. And the reason was that if I saw general med and then somebody sent me a diabetic and they said, I like you, I want to stay with you as my primary, as a diabetologist, you are their primary. So you have to think about, make it clear that you're not going to do primary care. You want to think about whether the diabetes is going to make you an internist as well, whether you want general endocrinology with diabetes or general endocrinology without. If you are going to do it with diabetes, you are going to have very little time to do the general endocrine otherwise. I don't have a lab. I don't have nuclear medicine. I have a lab, sort of. What I have is a contract that Quest Lab has one in my office. And in my state, and there are a few states in the nation that let you do this. California actually lets you do it as well. I can bill the lab for the ones that I want on my office visit, Quest charges me a certain amount, I do a markup, I'm still coming in less than their fee to the general public and less than the hospital fee for the same lab. So I'm giving the patient a break, I'm giving the insurance company a break in the cost, and I'm making a profit on the lab as well. So you may want to look into that and see whether that's legitimate in your area. I don't do my own lab, I don't do my own nuke med. If you can do ultrasound, and I don't do on-site adequacy, but I would recommend that you do. I don't do it because I've been doing biopsies for a very, very long time, and I've done thousands and thousands of them, and I know immediately before looking under the microscope whether it's an adequate or an inadequate biopsy. But I would say do the adequacy. You don't need a tech to do it. You do it yourself. Mark, you do your own, right?
Yeah.
Yeah, and Woody has the tech in the back doing it.
Yeah.
But most people do it themselves. You do the first stick, you walk over, you dip the slides, you look at it.
It's very easy.
And it's very quick and easy. And we teach that at the ACE Advanced Ultrasound course. There was a session on it in the ultrasound course we just did. So you can learn to do that yourself as well. The ultrasound itself pays very well. You saw Mark's breakdown. There was, I don't remember what percentage on the pie chart, but about 50% of my personal revenue, not my partner's, but about 50% of my personal revenue comes through from ultrasound, not from the E&M part of that visit. If I see a patient that's a Medicare patient for a level 3 follow-up visit, I think they're giving me something in the range of $70 for that visit, and they're paying me about $150 to do the ultrasound. The ultrasound, I can do almost any ultrasound in about 10 minutes unless they've got 35 nodules that I want to measure. So it's a very lucrative part of it. So the more you can maximize that within your practice, the better financially you're going to be up against.
And it's fun too.
It is. And I would agree with Mark. The second best part of my workday is when I have my hand on an ultrasound transducer. It's, you're looking at the screen, you're chatting with the patient, you're doing something concrete. The very best part is when I have a needle in the other hand and I'm actually doing the biopsy. And there are times when I would get really nervous about biopsies. I'd have some tough nodules. But like anything, the more you practice, the better you get, the easier it becomes. And there are days when I'll, walk out of the office having done 12 ultrasounds and 3-4 biopsies, and just say to myself, I can't believe they're paying me to have that much fun. I'd rather be out canoeing or kayaking or something. But if I have to work, I'm going to do something I really, really enjoy. I was not really enjoying sitting and looking at diabetics' feet and saying to them, I know you've told me you didn't eat anything over the last 3 months, but how come you gained 8 pounds and your A1C is still 12.5?
I promise I'm taking my insulin.
Yeah.
And I'm checking my blood sugar.
Yeah. Keep in mind that medicine is the one place that I can think of where it's easy to redefine your career. So I started out doing general endocrine. And then Jack Baskin started this ultrasound wave, and I went and took the course. I had had a background that involved ultrasound equipment development and all, so I had an interest, but I hadn't done anything with it in over 10 years. I took the course, and I said, this is great. I bought the cheapest ultrasound machine I could find, because I wasn't sure was anybody even going to pay me at that point. This was, going back about 10 years ago. I was saying to myself, gee, what if I spend $40,000 for a machine and I find that the insurance companies turn around and say, sorry, we're not going to pay you. So it was so uncertain then. So I bought the cheapest little teeny machine I could buy. I didn't even buy a printer. I stored the images and printed them out on
floppy disk.
Yeah, and then I printed them just on plain old photo paper at home at night for the few that I wanted to put in the chart. Within a couple months, it became clear to me that yes, I was going to get paid for it, and this was going to work. At some point along my career, I said I'm going to redefine and do just thyroid, and it became easy to do that. At another point in my career, I said, I'm going to bring in, another person to handle the other endo stuff, and I'm just going to shift it all. They can have all the existing diabetes in the practice. We're not going to take any new ones, but I'll give them all the PCOS, all the osteoporosis, all the male sexual dysfunction, pituitary stuff. They can have it all, and I'll just do structural thyroid. I can't think of many other fields where you can just say, I'm going to change the spectrum and scope of my career and do it and just have it fall into place.
And if you're in your business for yourself, you can make that decision today and implement it tomorrow.
Yeah. And the fact that I was in my own practice let me do that. If I was working for the Dartmouth Clinic and I said, gee, I want to drop all diabetes, the answer would have been no. And then when I said I want to just focus on thyroid nodules, now I'm going to approach them and say, look, this is my track record on being able to do this well, and I can come in and limit it, but I wouldn't have been able to modify it to that had I worked for someone else. And when I finally realized that the ultrasound was paying, and I wanted a good ultrasound machine, I didn't have to go through a committee and a hospital regulatory agency and the radiologist saying, no, we don't want him to have one. I went and bought an ultrasound machine. I had it paid off within 6 months from just the revenue from it alone, and then it became a profit. So doing that makes sense. The other thing that I think is probably among the best advice I can give is when I made the decision that I wanted to do this, it was at a time when I approached ACE about getting involved. And ACE put on, at that time, something called leadership development conferences. They were trying to train people to be leaders in the field. And so there wasn't a state ACE chapter at the time. And I said, what I'll do is I'll go off and take the leadership development conference and I'll start the ACE chapter. That'll give me a stature within my community. There are only, 20 or so endocrinologists in the community, but I'll start a chapter, I'll do it. Well, I went and took that conference, but that's when I got the interest in thyroidology and through ACE took the course. And I said to ACE, I really want to be involved in teaching ultrasound. I was brand new at it. But I approached them, and I had a lecture that I put together on physics of ultrasound and the history of ultrasound. And they let me give that at one of the meetings. And Woody remembers what a disaster it was, but I got asked to stay on after it.
And I would say the same with the ATA. One of the things is I got interested in nuclear medicine when I was in my fellowship, and I said, gosh, we have this fancy course, and I said, but there's no clinical data. And they said, you're the one. 1 year out of fellowship, I was helping give the course.
Yeah, and so if you...
So get involved with these organizations.
If you get involved in ACE, in Society, in ATA, they have a lot of committees they're looking to fill. And if you, let them know that you want to give them a little bit of your time, you're willing to serve on some committees and stuff, and say, I'd like to be on one of these committees. Look at the list of all the committees they have. Say, what's the best fit for me? You get yourself involved in something like that. You suddenly get a network of people that are real supportive to help you on everything else. You get mentors out of it. And in your community, people then start to see you as having a sort of expertise because you're on the thyroid scientific committee or you're on, it gives you something to base that on. As both of these guys said, market yourself. You've got to market yourself in the community. Market yourself. I didn't market to patients right off because I said, I don't want people calling up and saying, I'm fat, I'm tired, can I come see you? I wanted a referral-only practice. So I said, my best marketing is going to be to doctors, not to the population as a whole. So I didn't take out ads in the newspaper. I didn't take out ads in the magazines. But what did I do as my very first marketing thing? I wrote an osteoporosis newsletter. Now, you could similarly do the same thing with thyroid, but I wrote an osteoporosis newsletter, and I wrote about this brand new drug, Fosamax, that had just come out and how it fit in. And I talked about bone densitometry, and it was all brand new. So I mimeographed it or photocopied it, and I mailed it to every doctor in my referral area. And gee, guess what? I got hundreds and hundreds. The orthopedists in the area said, gee, we don't do anything with the hip fractures after we send them out of the hospital. Let's send them all over there to get them put on some medication. And I started getting 1 million consults to the rehab unit. In fact, it got so busy and I hated going to the hospital so much that I just established a protocol for them so they didn't even need to have me come in. But until I was making enough money that I was willing to never go to a hospital again, I got a referral on every hip surgery patient that went through that hospital. So, market yourself for those kinds of things. Lipids have been grabbed a lot by cardiologists, but you can go out and give lipid lectures. You can go give osteoporosis lectures. You can give lectures on, hypogonadism, estrogen issues in the female. There are all these things that, when you're trying to suddenly bring it all in. And now, since thyroid nodules are an epidemic, if you set up a practice and then you send out a newsletter to the community saying, these are the numbers, there's 57,000 cases of thyroid cancer expected to be diagnosed this year. 4% of the population has a thyroid nodule. What are you doing about this? What do you do when you find a thyroid nodule? This is what the guidelines say to do. I'm capable of doing this. The last paragraph, I'm capable of doing this all for you. You can send them to me. You don't have to think about the management of a thyroid nodule ever again.
I would add this, is that one of the things is that, as we all are getting more and more EMR based, spend some money and send some nice letters back. If it's a slam dunk hypothyroid, I will send my nice EMR note. I don't have one of these 1,500 pages of nothing. I have a 2 or 3 page note that's succinct. But I would say, one of the things I used to add at the bottom of every letter, I wanted to let you know that we're able to do thyroid ultrasound and FNA biopsies in the office. We also have radioactive iodine therapy. If you do have a patient that needs prompt referral, such as those patients with hyperthyroidism, please call at this number and we'll work them in very, very soon. Or just make comment that you're available.
Yeah. And then, certainly go give grand rounds. You got canned lectures from your fellowship. You've given the lectures along the way. As soon as you settle in that community, get yourself to do medical grand rounds at the hospital on hyperthyroidism, on hypothyroidism, on nodules, whatever. And if you're doing a more general one, certainly go in and give a talk, give medical grand rounds on osteoporosis or any of the other big fields. If you're going to do diabetes, give a medical grand rounds on pump therapy. Let them know that you are an expert in this, and that's something that they can send to you.
Amen.
The other thing I just wanted to mention, they talked about setting up the practice, and the practice consultant is very important. When I started back then, I hired a woman. She had set up 3 or 4 practices in the area before. She didn't work for me after we started. Her job was just as they said, that she's going to make the contacts with the insurance companies and get that established. She's going to make show me how to fill out an application for Medicare provider number. She's going to find me office space and tell me what's good, what's not good in the community for office space. She's going to help me decide, do I lease, do I purchase, and get all those things up and running. She interviewed and found me a half a dozen people to then interview as office managers. And I started the practice with one person working for me. I had an office manager who welcomed the patient, checked him in, brought him into I would go out to the waiting room and say, hi, I'm Dr. Levine, come on in, and I'd bring him in, and then she would, if it was a female that I needed to undress for any reason, she'd come in and stand there while, as my chaperone. Quickly hired a nurse after that, and now I have more people than I don't even know who half of them are at this point. But the importance of lawyers, we hate lawyers. Lawyers are just the bane of our life. But I have learned the hard way over the years that an ounce of prevention is worth a pound of cure. And having a lawyer who's a specialist in healthcare policy on a retainer for you is invaluable. You get somebody who, my current lawyer has been an advisor to the governor on healthcare policy. She knows HIPAA stuff inside out. She knows, all the business aspects. When I hooked up with her, the very first thing she said to me is, "What do you mean you're a sole proprietorship? You need to be a corporation." It was fine to be a sole proprietorship when you're by yourself. But you've got, 2 other clinicians working for you. You've got 12, 13 employees. If one of those other clinicians screws up, you're liable. They could come take your money. Whereas if you're a corporation and one of those other physicians screws up, they can only go after the corporation. They can't go after you personally. Nobody else had told me that. And so, you want a lawyer to deal with, are you going to be a corporate entity? Are you going to be a proprietorship? What about your own personal stuff, wills, trusts, protecting your assets? When you're
medical
hiring,
malpractice, and also if you were to get injured or sick, or what am I thinking of?
Yeah, disability
issues.
Right. And then what the other person that you want as a good consultant, as we're moving into an era where the RAC audits are coming along. Everybody know this, the Medicare hiring these independent contractors to come in and do audits. Dartmouth Medical Center just had to pay out, they voluntarily, they had to pay back $500,000 because their neurologists were miscoding. And it was found in a RAC audit. I now have somebody who is a Medicare auditor, but not a RAC one, who comes in and looks at my stuff and says, is it all legit? If they were a RAC auditor, they're going to do it. So, spent a few $1,000s for this person to analyze my entire billing system and say, yes, you're doing it right. They're not going to be able to come after you and say you're doing anything wrong. And if they did, the lawyer has told me now I could turn around and sue her and recover the damages. So you're going to deal with that for those kinds of things. So Medicare, there are even people out there who are Medicare application advisors. Totally different than this auditor that's coming in. Paid somebody recently just a few $100 to walk through the guidelines of getting one of my new employees a Medicare provider number and get under the group number and make sure it was all done legitimately. I got burnt because I didn't do it right once, and I had to give some money back. So having done that, that's where I learned the hard way about the ounce of prevention. You want somebody who's a good expert, and how did I find that expert? Through the healthcare attorney. She knows all these people. She's been working with them all along. And so she kind of designed the whole list of everybody else that I needed to make sure it was all being done right. How do you know about something like, making sure your office is HIPAA compliant? And what do you do if you find that, accidentally somebody faxed to the wrong number? And, so that's where having somebody that really knows how to do it is a good one.
In terms of the breakdown, it really depends on your demographic. So I don't think you can pre-select a certain percentage. You'll develop a percentage, but that's not an initial goal. My initial goal was to do thyroid only and to take every insurance company that was reasonable. In other words, at least 100% of Medicare, preferably more. And then in terms of the authorizations, we learned the hard way that if they weren't authorized for everything, that we didn't get paid all the time. So our staff goes after that, and until they have that on the file, the authorization codes, they don't come in as a patient.
Right.
So we just push it until we get it. Or then we tell the patient if we're having problems, we say, we're having trouble communicating with, it's not our insurance company, it's the patient's insurance company. So to have the patient get involved in dealing with their insurance company to help get that authorization for the visit.
The other thing you can do right now, and this is one of the things in my office, we always make sure that before a patient gets referred that we have records, number one. We have records, and we have valid insurance information that has been validated the day before the appointment, or sometimes weeks before the appointment, to make sure that the policy is valid, so you can in turn let the patient know your out-of-pocket will be X. and we're right on it, and a lot of people, they just take the $10 copay, but you can go ahead and say, this is what your responsibility is going to be. We need to have it at the time of the appointment, and they're all notified.
And I do it the exact same way, right. Especially in terms of that I want records before I actually give the appointment. So the patient calls up and says, my doctor told me that I have a lump in my neck and I need to see Dr. Levine. The secretary says, we need to get whatever it was. So I'll take that there was a note where a doctor said, I feel a lump. I'll take an ultrasound, and I want a TSH before I see him as well, so that although Woody would just do it at the visit, I want to see the TSH ahead of time, because if it happens to be 0.001, I may even have that patient already go off for a scan before I see him. And often the patient will walk in with a 0.001 and no T4, no T3. And so I can get half the case done before they walk through the door if I've gotten the records, and I review them that day.
Or the other thing I would point out too is you get so many referrals for a TSH of 6 in an 85-year-old person that's on Synthroid 75. And you pick up the phone and you call the primary physician and say, gosh, let me tell you what to do. Just do this. You recheck it 2 to 3 months. And they love that you took the time to do that, but it buys you time as well.
You're not going to do that in your first 3 months.
Right.
You're going to do that after 6 months.
After 6 months.
In the first 3 months, you're going to
see everything.
You're going to send the patient back a letter
TSH for
with
the stars,
a detailed examination, and you're going to talk about in that letter, that in recent times our goal for where the TSH should be in this elderly patient has changed, and we no longer are looking to get them between 0.5 and 2, but in this patient now I'm kind of looking to get them between 1 and 3 because of their age. This is very new information, and then thank you so much for letting me participate in the care of this really pleasant patient. They love it. And that's something else that Woody said is, I don't have a fancy EMR system. I don't generate the 10 pages. We have a homegrown one.
You're going to need one. You're going to need one.
I'm going to need one, but I'm holding out as long as I possibly can. I have an electronic record, but it's one that a medical student designed for me. And it's a PDF form, and it's designed to make my life easier, not to make Medicare happy. At some point, I'm going to need it.
You're going to need one.
But I'm holding out as long as I can.
But that's about a $50,000 expense.
Dartmouth put in an Epic system, and their productivity fell by 20%. I put in my own homegrown, and my productivity went up 10%, which is more than they were going to boost me for the incentive bonus to put one in. So at some point I will. So I don't generate a 5-page letter that the first line is, what language are you most comfortable speaking to your provider in? I generate a letter that says, thank you for referring Mrs. Smith for a thyroid nodule, and then has all the blanks filled in. The one part that I don't like about what I do, by doing as many ultrasounds as I do, and I want to keep my productivity real high during the day, I don't take the time to write the ultrasound report immediately upon doing it. I take notes. So every night I go home and I have about an hour of homework where I have to generate my ultrasound reports.
How many of you all are signed up to come to the Endocrine University? We'll be talking about ultrasound reports there.
Yeah.
Look forward to seeing you there.
But what you want to do is decide what's the most important things in your life. And 20 years ago, the most important thing in my life was building that very solid big practice, and I worked all the hours and I loved it. At this point, the most important thing in my life is time off. And I take every Wednesday off, and I take 12 weeks per year off for vacation now. I could cut that in half and probably make $150,000 a year more. But my choice is to have a lower income and a much better lifestyle at this point. And you make that decision and it evolves. My wife works for a hospital or a medical center. She does not get 12 weeks off a year. She gets 4 weeks off a year. She hates it that I have 8 more weeks off than she does. But she can't get it because she works for somebody else. And the only way that you can at some point in your life say, I really now am putting a priority on taking my time to myself, is by working for yourself.
We'll be up front if anyone else has any other questions. Thank you all for letting us speak.